So the next talk is from Francesco Pegoraro. We now know is Francesco Uno, the first Francesco.
Thank you, Matthew. And okay, thank you. Well, I know some of you already heard this presentation, but I'm very glad to present this today because I think these results are very meaningful for the community, and also, and more importantly, because I'd really like to discuss some of the potential implication of these results with you. We know from the work of our French colleagues that patients with ECD frequently can develop myeloid neoplasms, and in about 10% of patients. And we also know that up to 40% of ECD patients have clonal hematopoiesis if you look at the bone marrow. More recently, our Dutch and US colleagues have also explored the risk of cancer in patients with LCH, and they found that adults with LCH also have an increased risk of cancer. So starting from these observations, we tried to look at how ECD patients, if ECD patients developed second cancer, but not only hematologic cancer, also solid cancer, to describe this second cancers associated to ECD, and to look if patients who developed cancers were different from patients who did not develop cancer, to compare the incidence of cancer in ECD as compared to the general population, and to analyze potential predictors of cancer in ECD patients. So to do so, we retrospectively analyzed patients with ECD that were followed at two institutions in Paris and in Florence. And we identify out of more than 500 patients who were followed for a median time of more than 5 years. We identified 146 patients with second cancer, which accounted for 28% of this cohort. There were hematologic cancer in 73 patients, solid cancer in 87, and 14 patients had both cancer in their natural history. And this was made out of 500 patients, and what I looked at more recently, because, and I will present more broadly this data later in the afternoon, but I checked if in a larger ECD cohort that we have developed since then, if these results were more or less the same, and actually they are, because out of more than 1,000 ECD patients, the percentage of patients who develop second cancer is quite the same. It's 26%. So when we look at this cancer and we look at hematologic cancer, as it was already reported by the French colleagues, is that the most of this cancer are MDS and CMML, but also myeloproliferative neoplasms and other less mild and other non-myeloid cancers. While when we look at solid cancer, we have very, very typical cancers such as prostate and breast cancer, but also less frequent such as thyroid and as a bit more expected skin cancer. This cancer developed all over the natural history of the follow-up of these patients, but you can clearly see that most of them were diagnosed close to ECD diagnosis. So there could be, of course, a bias in screening of these patients, but there might also be something more related to the diseases, and this is something that could be intriguing at some point. So we also looked at differences in clinical presentation between patients with and without second cancer, and of course, we expected this, but we confirmed that patients with second cancer were older at diagnosis, were more frequently males, and more frequently had cardiovascular risk factors, but also they had also much higher frequency of clonal hematopoiesis. Then we seek to look if the risk of cancer in ECD patients was increased as compared to the general population, and we did so with a parameter which is called the standardized incidence ratio, and which substantially tells you how much more frequent it is a condition as compared to the controls. And for ECD patients as compared to the general population, there was an almost 5-fold increase in the risk of cancer, which is quite a lot. We also looked if what was the cumulative incidence of cancer after the ECD diagnosis, so only after all those cancers that were diagnosed before ECD were not in this analysis. And we can see here that while hematologic cancer have kind of peak quite close to the ECD diagnosis, for solid cancer the increase of incidence is quite constant over time. In the 500 patients cohort, around 30% of patients died at, I said a median follow-up of more than 5 years, and this was up to 45% in the cohort of patients who had second cancer. However, causes of death were mostly related to ECD, and only in 15% of patients this was related to cancer. And this also reflects in the probability of survival, which was compared between ECD patients with or without second cancer. Because at the first look, patients with second cancer seems to die more, but when we did the multivariable Cox correction for age and gender, this significance was lost. So these patients were older, and they probably and they likely died because of older age. And similarly, we did not find any difference between depending on the type of associated cancer, so hematologic or solid or both. Finally, we did look if there were some factors, ECD related, that were associated to an increase of risk of second cancer. And what we found is at multivariable analysis was that age and multisystem ECD involvement were associated with an increased risk of second cancer, and that female sex, and this is quite hard to explain for me, but hypothalamic pituitary involvement were associated with a lower risk of second cancer. So I think that there is some nice perspective and discussion that we can have on these findings, because the first thing that we thought of was clonal hematopoiesis, and this was a bit already discussed by Fleur and Julien in their blood paper in 2021. So could we speculate, because we know that clonal hematopoiesis is associated not only to hematologic cancer, but can also be associated with solid cancer and cardiovascular disease, and all of these can somehow be implied in an increased risk of cancer. But what comes first, I think we still don't know. So it's clonal hematopoiesis that predispose somehow the patient, the bone marrow, but also the patient to cancer, or is the other way around? That I think we don't know. We can always think, and this is when you think of cancer, to a common predisposition, and when you think of ECD, there are some things that come up. For example, we have identified in our GIVA study, to which many of you contributed, that there is a risk locus for ECD in the intronic region of ZBP1, and this has to be explored further, and we are doing that. But one could also speculate that there could be some common predisposition that is shared between ECD and cancers, or and we are exploring these with the Geisman lab, as they described somatic mosaicism as part of pathogenesis, at least in neurodegeneration. That and this came up to us because we had some patients that had ECD and a second cancer, solid cancer, and these two entities share the same BRAF V600 mutation. And so one could speculate that there is some mosaicism in the mutation that gives rise to ECD on one hand and associated cancer on the other end. And finally, when we think of cancer, we always need to think of the environment. And Francesco very elegantly described the clustering, geographic clustering of ECD in Italy and France, which was inversely associated with a developmental index, but it's something that we really see in our practice. Many ECD patients comes from regions where the oncologic but also the environmental risk factor are much higher. So to conclude, we demonstrated there is a striking association between ECD and second cancer. That this is much higher as compared to the general population, and that we need to find a explanation. If we think of a possible explanation for this, we can speculate on many things, and I think any of these possible explanation is very interesting and needs it could be worth being explored. And of course, the final main message for all of us is that we really need to screen ECD patients for second cancer. And I especially thank Augusto and Julien, who were the seniors of this project and of many other projects that we share and that I'm really happy to do. And I'm happy to take any question.